something a bit different today. We've managed to get a hold of Dr Mary Wyatt, who I've known for 25 years. You wouldn't know it by looking at her because she looks about 32. I've spent a lot of time with Mary in the trenches when I was doing occupational rehab. Learned a lot about how IMEs approach things at that point in time. Mary's been doing a lot of work lately on It Pays to Care through Safe Work Australia. Welcome, Mary.
Thank you, Simon. Yes, we do go back to kindergarten. Hey?
Back to kindergarten. Mary used to drag me out on
From
work sites.
kindergarten.
Yeah, Mary dragged me out on work sites at 6:30, 7 o'clock in the morning to do her work site assessments, and I was 20-something years of age, and that was not my ideal time of the day. So, Mary, look, you've done a lot in your career, but the latest thing you've been out there working on is It Pays to Care. Can you give us a bit of a rundown of what it is and what you're trying to achieve through the program?
Yeah. So look, what IMEs are, we're not a very good brand at the moment, but doing independent medical reviews for whatever, 30, 35 years, I don't think there's a better way to see what's happening in work injury schemes than actually through doing IMEs. So we are story listeners doing an IME. And, if you think of qualitative research, they're kind of 25. Once you've done research on 25 people, you've got the themes. Well, I've said 20,000. And I have to tell you, a certain proportion of them are roadkill, and they're human roadkill from systems. And of course, that's a fairly dramatic statement to make. And there is a spectrum. And I think at the top were the people who appeared in the Victorian Ombudsman's report, the second one and the first one. And then underneath are the people I see at the moment. So I'm doing IMNEs for common law claims, and these are people who are 3 or 4 or 5 years in. 80% of them, WorkSafe data, are depressed, and that's exactly what I see. And there are so many preventable things. So I'm a doctor. It's about the community we serve as doctors. And so I've been an IME, I've been a treating GP, so I know how bloody hard it is for GPs. I've been a treating occupational physician, I've worked at workplaces, I've run an early intervention program as the operational manager at the workplaces. So with, a lot of big employers, so I have my fingernails dirty with rehab. I've been a conciliator, I've been a researcher, I've been a teacher in teaching doctors and others. So I guess I do care for what happened really for the workers. I see the police commander who can't answer the phone because they're just going, they can't deal with what that's outside of their control, to the 18-year-old kid I saw 2 weeks ago who can't go out during the week. She's got to be with her father all the time because he's had a claim and it's just gone like it's gone. So these are the cases that I'm talking about, a human roadkill, but it's also employers. Like, I'm an occupational physician, so my medicine is medicine, and I keep up to date with that. And then my occupational physician thing is we understand workplaces, and workplaces are important to me. I kind of see what line managers do and what they're not trained in. So anyway, and then I've kind of got a pretty good understanding of the healthcare side of it. And I spent a lot of time, particularly developing this policy on talking to people, talking to CEOs who've run organizations and made the major changes to schemes, to the ones who haven't, to the people who are at the claims manager level, to the policy people. So I guess, Simon, I'm trying to say to you, I've tried to look at this from as many angles as possible to understand what's going on. And I guess that's the genesis of It Pays to Care as the policy and the absolute intent of the policy. And we've got a team of people. We are purpose driven, and it is about what we can do. Chris White, CEO of WorkCover WA, says we're trying to change hearts and minds, and we're providing practical tools. So we really are having a shot at trying to improve schemes for everyone, because there are so many stupid things that happen. So many stupid things that happen in healthcare, at claims level, at policy level. It's just hard to believe. So a lot of opportunities for improvement. I'll stop there, Simon.
So with that, Mary, you talked about working as a GP, and one of the papers, or one of the things I shared with you prior to this, was the Safe Work Australia statistics, which is showing that the number of claims where there is no lost time has been decreasing over the last 5 or 6 years. So I think one of the papers you wrote a while ago under Return to Work Matters said that 75% of all first certificates are unfit certificates, and now that seems to be dropping. What's the genesis for that? Why is it that more people are going straight off work instead of actually getting back to work like they used to?
I don't know. I don't know the answer to that, but I can put in a few things that might be contributing to it. So I was a GP and I remember stuffing up cases, trying my best, but having no idea. That was in the 80s, late 80s and 90s. Um, And so it's just a whole different world. Like somebody comes in with a back problem, we may have an understanding about how to manage their back problem, and musculoskeletal medicine is only a very small part of what we do. But then there's this whole other world that's happening outside your rooms that you got no frigging idea of. And so you just, what do? You just don't know what to do. And so, like, I had conversations with people telling them they needed to go back to work, and they just walked out saying the doctor doesn't understand and we'll go to the next doctor. So I failed in those. I failed in addressing psychosocial barriers. So I think we need to understand psychosocial barriers are the reasons people don't go back to work 85% of the time. It's massive. And we as doctors are very biomedical. So you're telling me about how terrible your back pain is. I'm not thinking, is this distress and pain? I'm just hearing you're in such a bad way. And so I respond to that medically. So I give you more drugs, or I send you to a surgeon, or I send you for an MRI scan because I don't understand what's going on for you. I don't understand that your supervisor's a dick and that you're not telling me that. And you don't know enough as the patient to tell me that. So it's kind of the blind leading the blind. And I was astounded last year because there is some movement to try and do better with general practice in a different way via PEEF and doing some advanced training for GPs and supporting the development of a community of practice who are kind of like specialist GPs. Probably not the right word at the moment, but in other areas in medicine, general practice do specialisation. Like I was a GP obstetrician, so I was delivering babies as a GP, and people nowadays might do a mental health. So anyway, it used to be part of the GP training. You don't learn about it as undergraduate. Monash, you do. But generally, doctors don't learn about it as undergraduates. We learn our medicine, our real medicine, in hospitals, in intern and residency years. So that's where it's an apprentice model, really. And so that's where you learn, and you don't learn anything about workers' comp there. Then you might go to your GP training. Well, I didn't. It wasn't happening when I came back to general practice. But now it was in the general practice postgraduate training up until 10 years ago. And I just learned from running a course. I teach doctors once or twice a year in a short course. And I ask them, and like South Australia really runs quite a lot of training for GPs and other healthcare providers. But around the country, it doesn't happen. So they're not doing any postgraduate training. And a lot of them are overseas trained doctors now. And so they haven't even grown up with workers' comp. So we're expecting doctors to deal with these situations and then look at general practice. The freeze on general practice really has damaged general practice. And so you just got to do more with less. And so you've got to cut corners and you don't have the time to do the psychosocial and the old-fashioned GP of I knew all the specialists in my area and I'd refer to them. And, medicine is quite different. It's much more transactional and patients' expectations, and it's much easier just to follow the patient's expectations and try and have psychosocial conversations. Because you've really got to be adept and trained to have psychosocial conversations in this environment. Psychosocial counselling is an extraordinary thing when it's done well. We've got massive benefits when we're looking at around the country. There's massive benefits from this approach at a systematic level. But I said, we'll get providers. We're just not trained in it. So is that sort of answering it? There was a big study from Alex Colley and his unit at Monash, the Professor Alex Colley, and they studied the certificates and what's happened over sort of 10, 20 years. And absolutely, we're just shying away from it as doctors. We're just like, it's just too hard. Let's just do what the patient wants. And that there's a lot of medicine going that way generally. It's not just in workers' comp. Should I stop there?
Yeah.
Should I stop there, Simon?
Yeah, Alex, you were making some notes throughout that.
No, I was just listening to what Mary was saying, and it's pretty clear that they've got a lot of barriers around being time poor and don't have that time to take that holistic approach at looking at the whole person rather than just the injury itself. So focusing on the injury but not looking at the whole person in terms of what else is going outside the injury with work and things like that, because we always look at other motivations as to why the worker's off work. They've got the compensable injury, but there's usually other factors that are delaying their progression of getting back to work. So yeah, that was...
And that is spot on. And I will just speak for a minute there, because half of the reason we wrote It Pays to Care, which is a freaking huge thing to do, was just that. The evidence. So we've talked about psychosocial stuff for 40 years. And like so many people, I've been like, yeah, well, what do you do about it? Fine to talk about it. Yellow flags, blue flags, blah, 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 blah. We really haven't made progress. But then in the last 5 to 10 years, we have. So we've had the WISE study from New South Wales. We've had the MCAP study from Australia Post. We've had the Navigator Support Group. We've had Access Rehabilitation. There's been these centres of people doing this, and we can identify the people who have got psychosocial barriers within the first week, and we can put things in place that are simple. 5 sessions of counselling has been the typical used, and it's a massive reduction in long-term disability, 20%, 30%. It's extraordinary. So, if I can give you a message today, really try and understand about this as much as you can. We have written a policy, an 80-page, well, I shouldn't say policy, a best practice guide, how you implement this at a systematic level. If you look at the It Pays to Care website and go to resources, it's under there, or biopsychosocial, I keep forgetting. And because it's a massive opportunity to really make a big difference.
So, Mary, one of the things I sent you was a study that WorkSafe had done here in Victoria. And they identified that only, on average, about 3% of a GP's patients were on workers' compensation. Do you think that also plays into it, that where they're actually not getting enough, exposure to the system to understand how to do it? One of the things that I remember, because I'm getting older, back in the early 2000s in New South Wales, GPs knew how to bill for their time. If they took a phone call, if they sent in a letter, all that sort of stuff, they knew how to bill for it. Are doctors now, at the moment taught these are the things you can bill for, which might make them more prepared to return phone calls, send letters?
I absolutely think that would help. I think there are many barriers. One is you've identified, Simon, that it's just out of our depth. Like a simple patient, yes, cut their finger, blah, 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 but the psychosocial stuff, we're out of our depth. And that's not going to change. It's not going to change. It's not going to improve.
But does that mean, Mary, that employers need to get better at actually identifying what might have been at play in the background of a claim so they can raise it with the doctor, get the doctor to raise it with the patient?
Well, I tell you, Simon, I go back to 20 years ago. I was involved with a group called OCCORP, OCCORP, I think it's still going. And we worked with employers. So we worked with Visi, NILEX, Royal District Nursing, aged care facilities, manufacturing, automotive. And there's proper peer review. Like we had a 40% reduction in claims costs and a 60% reduction in days lost from work, across 800 claims. So it's a decent sample across all. We had WorkSafe data. They extracted the data. They extracted the data for 2,700 match controls, age, industry, blah, 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 blah. And that was workplace based. So our whole focus was keep the workplace relationship positive. And we did a number of things to make that happen. So we would start with the most senior people we could work with. Because if the line manager's not playing ball, you've got to be able to go to the production manager and say, this is going to cost you $86,000 the way you're going. And if we do it this way, it'll be $22,000. And if that doesn't work, you've got to be able to go to the next boss up. And so we would structure it so we were working with the workplace and influencing the workplace and at a case level and at a system level. And so the best example I can give you is a woman who had a shoulder problem. She was so difficult that the union wouldn't even deal with her. And we got the production manager and the line manager together and say, this is how you do it. You come and talk to her for 5 minutes a day, check on her, ask her about her well-being, blah, 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 blah. They did all of that. She came back to work. She had shoulder surgery. She came back to work and it all went smoothly. And it's that so for us, we rarely had problems with doctors. We would try and help them. We understand doctors because, we have medical input. So do you need an MRI? Like it's a 30-year-old with a big swollen knee. Do you need an MRI? Let's us help you get the MRI. You need an orthopod? Let's get you into this guy who does the footy players. And so you're really trying to smooth that transition. And that had extraordinary benefit. And over those massive number of claims, we disputed 4. Now, we did that because the employer was an assistant and the evidence they gave us suggested it, and we went down on all 4 of them because we were, you think you know it, and then all of it more comes out over time. So for us, the only way to really be effective was to keep that relationship at the workplace. That's the biggest part of it. Of all the psychosocial stuff, that's the biggest. The second business is passive coping in the form of difficulties. Different people have different coping styles. Some of us struggle, some of us are more robust. So where are people on that spectrum? How can we help them? And when we do that counselling, we see them get back to low risk and we see them coming back to work, and it stops a lot of it. So I've probably got off track.
So, Mary,
bring me back.
One thing you're talking about there, and we work with a lot of our clients on this, is that it's engagement. If you lose engagement with the work or you don't build engagement with the doctor, you're out of luck. And there's something I heard presented at an eye care seminar a few years ago, and they pointed out that if a manager reaches out to the worker, so not the return to work coordinator, not someone they don't speak to on a regular basis, but their manager reaches out within 48 hours, it increased return to work outcomes something like 400%, because the manager is now showing that I value you, I care about you, and the fact that you're off is something that I want to work with you on, as opposed to we've had companies tell us, oh yeah, we don't contact the worker until the doctor clears them. And you can imagine by that point in time, if they're just, no one's putting suitable dues in front of a doctor, no one's bringing the worker in to meet with them, and hey, we want you part of this business, how that claim's going to go. Now, Kathy, you see a lot of issues in your line from the strategic point of claims that have just been dumped before they started.
Yeah, absolutely. So agree with your point, Simon. It's all about, relationship and engagement and engaging that individual early on. But also, Mary, just a question for you. Do you think that doctors actually underestimate how much influence they actually have over their patients?
Well, maybe. I actually don't think doctors have much influence, really. So if we look at the evidence again, this is stuff Tyler Lane of Monash worked on a few years ago. But if you look at, us docs make a difference in the first few months.
Absolutely.
It's treating the sprain, the strain, the blah, 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 the more medical side of things. Once you get beyond 6 months, we actually don't make much difference. So I'm actually going through the 2025 Return to Work survey. SafeWork has given me that data. Last time I was commissioned to do a report for them. This time I'm just doing it independently. But I've got the data and I'm working through it at the moment. But um, the the key thing is just that relationship. So reciprocity is a bigger message from me. Reciprocity is that thing your mother brought you up on, do unto others as you have them do unto you. And so if you treat people well, they respond in kind. Of course, it's not everyone. And if you treat people badly, they respond in kind. But in fact, for both the positive and negative reciprocity, they respond more. So this is proper research studies. You give people a bottle of wine and what do they give you back? Or this, you do that. And it's across a range of areas. So what do? You kind of, you treat, the people feel like they're being treated with suspicion and they might overreact. Like we're all people. It's not like we're robots, we're humans. And so we misjudge things and misunderstand things, and our own minds. The psychosocial is not confined to workers. We're all got stuff that influences us, whether we're going for a pay rise or trying to deal with a problem with our cousin or a fight we've had with our sister. All of these beliefs and things that go on in our mind are real. And then when we're in duress, like having a claim can be for some people, the oncologists see this for cancer. People are under duress and psychosocial stuff comes out. They need extra support. There's more distress. And so if we can understand that and support them through it, particularly as employers, we're like halfway there. Look after them, nurture them. We used to have loving lessons for supervisors in automotive because that's a pretty tough industry and you wouldn't do it now. But loving lessons for supervisors is a bit kind of, not me too, whatever. But, they would say, yes, we're getting it, love them, we're loving them. And so it's really that, engaging people, working with them. That is, you're spot on, you guys. That is exactly the thing.
Yeah.
And it's that feeling you're wanted and that you're important enough to be cared for. And you're not a bloody KPI statistic. That's another really strong message to workers, that they're a statistic rather than it's them that's being cared for.
Now, Mary, you raised being a GP through the 80s and 90s. Back then, we were, if someone had a back injury, we were putting them in bed and telling them to have bed rest. Late 90s, early 2000s, we went, well, that doesn't work, we've got to get them active. I'm seeing that now when we look at mental injuries, that doctors are sending people home, and we know that social withdrawal is actually reinforcing the condition. Yep. Again, this need to educate doctors so they can educate their patients. Because back, when we went from that transition of it should be bed rest, there was a bit of pushback by workers. Oh, what do you mean you want me to be active, and get out there when I've got a back injury? What do we need to do to get that working? From a psychosocial perspective, psychological perspective, say, hey, I understand you're feeling depressed and anxious, but the worst thing for you is to go home. How does a doctor get there?
Well, we're still, yeah. Look, I think we need a concerted effort to continue it. I mean, the public health campaign in Victoria, which you might remember, and maybe some of your listeners won't, was really about don't take it lying down, and really smart ads to say to people it's really important for you and your bag to keep moving. And people really got that message. Data, you saw it in your clinical practice, etc., etc. And we lost that. There was a different message of the different government 5 years later, and it's like the guy in the wheelchair next to the conveyor because he's been hurt. And medicine has done what medicine has done. And we were trying to say don't do scans in the 90s, and they've just escalated since then, and the outcomes are worse. So we're doing a lot of terrible healthcare. We've written a series in Return to What Matters. If anyone's interested, they're freely available. There's a sort of a healthcare series kind of block at the top. But we continue in the physical side of things to disable people. It's huge. It's just there's more and more evidence about scans and the harm they do, randomized controlled trials, etc., etc. So we haven't improved on that. Simon, the physical, we've just got worse.
And I think
And the same thing's applying as you're talking about for mental, just as bad. We don't know what to do. We don't know how to be proactive in the rehab. We don't know how to influence the workplace. You know, I mentioned it before we started this podcast. I think we need to teach doctors to call out psychosocial hazards. Like there's a return to work and the supervisor's treating the person badly or they're lost with what to do in the duties. We need to say that's a psychosocial hazard of return to work and give the doctors the tools to declare what it is so it can be managed rather than just writing unfit certificates, which is what's happening at the moment. The doctors, what they can do is protect the patient, and if they can't manage what's happening at the workplace, that's their instinct, is to protect the patient.
And we were talking before, Mary, about someone comes in, you don't tell them what they want to hear, so they walk out not happy with you. And we know in many states they might then go to another GP down the road and get that person to see them. So that continuity of care goes. Or they're seeing going to a bulk billing clinic where the doctor they see changes every time. I'm not sure whether there's any data on this, but New South Wales that has that nominated and treating doctor that you have to go back to, do they get better outcomes on on that physical side of things due to continuity of care?
I don't know. It's a good question and it's timely because, as I say, I've got the return to work survey data, which is just the best database of looking at return to work in Australia. And there's such a longitudinal, 20 years, 30 years of data. So I'll think about that because there was something different about New South Wales doctors. So, and I didn't think of that NTD, the nominated treating doctor thing. So I'll go back and I'm probably a month, I'm setting up to meet and talk with Safe Work Australia about it, about what I've been seeing, but I'll look at it from that perspective. Yeah, thank you.
That'd be interesting.
I don't know at the moment.
So if we look at that, a lot of what we were talking about, that the doctors are limited in what they can do. And a lot of what we do when we're out with our clients is actually talk to the employer about stop putting everything in the hands of other people. The expectation is the doctor will fix it, the agent will manage it. So, I guess, Alex, from your perspective, what are some of the simple things that an employer can do to even just get better outcomes from a doctor?
Talk to the doctor as a start. Because in this document here, the Return to Work Matters document, you got Mary, the stat that says 66% of doctors saw the certificate of capacity as the main way to communicate with return to work stakeholders is pretty concerning in itself. It's probably more on the employer's side actually having the confidence and skill set to talk to treaters. They feel probably maybe intimidated to talk to a doctor. And then they just don't pick up the phone and start that conversation. I think if that was to occur, you would see better. You'd see less unfit certificates because then the treater would be have a lot more understanding of what's going on within the workplace. And they may pick up on some of those psychosocial factors as well. You mentioned, Mary, in those meetings as well.
I think you're right there. Look, it's establishing the relationship. I don't know what it's like. I haven't been in general practice for decades, but we used to work on relationships. You'd have a relationship with 2 or 3 local surgeons. One you knew, like this is technically good, and you'd send that kind of patient to them, and you have a relationship with the physio, and blah, 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 blah. And we do work on relationships. I don't know, it's the same now. But once again, if you've got the worker wanting to go back to work, and I think the employer is the biggest influence on that. The data says that across the board. The Tyler Lane stuff, I got sidetracked from that, but what it says is after 6 months, it's the return to work coordinator. The odds of going back to work are doubled with a low stress encounter, i.e. a good encounter with the return to work coordinator, and obviously the opposite. And so the evidence says the workplace has much greater influence once we get to the psychosocial stuff. Yep. And so I would say to you, it's not just communicating with the workplace, it's communicating with the worker, because the way to the doctor's heart is through the worker. If the worker wants to be back, if they trust you, if they feel they're having a bad day, someone will, kind of be okay and help them out, or they're wanted or they're valued, you are 2/3 of the way there. Because then if the worker wants to come back and they trust you, then the doctor will follow suit. So I always say, if the doctor's writing unfit certificates, don't go to the doctor. What's going on? You sort out what's going on find out, and then what can you do to help the doctor? The way to a busy person's heart is to help them. And what happens for doctors is they're just getting, the claims agent wants this. And you know what we're all like. One bad experience, it stays, and you've got to have 6 positive to reverse it. So we've all had that. Doctor being put under pressure, the employer's trying to put you under pressure to send them back, the claims agent is. So help them, developing the relationship via the worker, and then help the doctor.
Alex, you had something else you were going to say there for?
No, I was just going to say that the amount of times that we talk to an employer and they say all our workers go to this doctor and it's Dr. How Long, but you're not really sure what kind of relationship they have with that doctor, or do they talk to that doctor. So, we see that happen a lot, the old Dr. How Long.
So, Mary, one of the things...
There are no doubt a handful of doctors around town who are just that. But the vast majority are struggling, lost and struggling.
Mary, one of the things, we run a workshop called Engaging Doctors and Workers, and it's about helping employers see what they can do to try and control the process a bit more. One of the things we talk about there is what you raised before. Doctors are busy. And someone will call, like in the middle of their consulting hours, and be perturbed that they can't talk to the doctor, and that, and they keep leaving messages. We know someone who left 10 messages for a doctor that day, and then wondered why the doctor did not call back. When I used to do rehab, we knew that doctors had usually set aside a certain part of their day to make their phone calls and that sort of stuff. So I'd often ask that question when I first spoke to the doctor. Okay, when do you normally make your phone calls? If I need to talk to you, if I leave a message, I'll leave myself available. Does that work? And by then saying to them, you can get back to me when you're ready to do it, as opposed to I demand your time now, and that's going to make you late on everything else you do for the day, got a better outcome.
Absolutely. Simon, you've mentioned Return to Work Matters a few times, and we've been at this for 18 years now. We're actually developing a chatbot out of it because it can take it from information to how to, which is the superpower of AI. Anyhow, I digress. We have a few articles, and if they're not free articles, we've got quite a few free articles. I'm happy to give a free copy that you can share with your people if you would like. But we've got some practical articles there about how to reach doctors. But some of the things you've talked about, develop a relationship with the practice manager or one of the receptionists, because they're the people who are the conduit. They know how the doctors work. They know, do they have a time schedule? Is it best to book some time? Are they just so pissed off with workers' comp they're never going to talk to anyone? So work with the practice. Try and make time in advance. If you can talk to the doctor while the worker's there, it's way better. Whether you can get the doctor to give you a call, so the doctor's got somebody seeing at 9:15, you go through the medical aspects of it, you've asked to book a long consultation, and then the doctor rings while the person's there. I think that's a good arrangement. I love going to work sites because I think it's the relationships. If you can go and see, like I'm used to it, but you feel what's going on, you feel the relationships. Is this a factory that looks like it's out of the dark ages, but it's really warm and they care for each other? So if you can kind of get a sense of that, I think that helps the doctor. But, in your opening emails to them, get ahead before the patient's there. You want to help them. You want to support them. Ring me, tell me what you need. Here's your phone number. We want to work with you on suitable duties. If you need, we know it can be difficult through claims at times. Can we help you streamline any treatment? That big thing of can we get you an MRI if you need it? Save that doctor time. Can we get you a good specialist? We know the patient's going to love because he does the footy plays and they all love that. So help the doctor. Yeah. Yep. Lots of different ways. And of course, doctors are like everyone else. So we've got from really superb to, not really interested. So you got to kind of gauge it.
From an employer perspective, one of the things that I've seen probably change in the 25 plus years I've been in the industry, I think in the last probably 5 to 10 years, I've seen them become a bit more aggressive is probably a hard word, but almost antagonistic towards injured workers. That, we've gone from understanding that, if we look after them, they come back to work, and there were some great workplaces that we dealt with years ago, to a lot of people now think premiums are going up, they've had a couple of bad claims, so therefore every worker's bad, and I'm going to ride every worker instead of trying to care for them. Have you come across that?
I don't see enough of what's happening at the grassroots level to see that, Simon. So I don't know. I can tell you the data side of it. Again, I'm playing with the return to work survey data at the moment. And one of the things that's really stood out, and I've got to check the data and look more cross-checking, et cetera. But one of the things that's really stood out is the drop in workers who say their employer has been constructive in their approach to dealing with the claim. And that's really changed quite a lot in different jurisdictions. So some have dropped a lot, and some have dropped less. But certainly the data is saying employers are being less supportive. And I kind of think, like, this is not data, I don't know, but I'm surmising they're just a bit over it. They don't feel they've got control over it. They see it, like in Victoria, I think they see that it just gets away from them and they don't have any say. And so they just try and do what they can when it starts out. But I don't really know that. You probably be better on the ground seeing what's actually happening.
Now, don't know whether you read it. Greg McCarthy, who used to be the CEO of Return to Work SA, wrote a great white paper probably about 10 years ago now. And one of the things he started to talk about was when people aren't engaged, when they're left on a system, that they tend to almost develop this entitlement to compensation. They get caught up in that scheme. And it's quite difficult at that point to try and move them off the scheme. So there's people who, there's no longer really an injury. The reason for being on comp is more the fact that they don't want to go off comp. Now, you've put the red rag up before when you mentioned the Ombudsman. It's one of my, those reports are my pet peeves. Statistically unsound, a whole lot of issues, but the damage it did to the scheme here in Victoria was immense, where she was having a crack at agents doing what they were... Pendulum swinging.
Yeah. Too far.
Yeah, so, and making the agents out to be immoral and unethical. Now, Alex, you were at CGU at the time. Can you remember the really good response that CGU put into them about why they do what they do, about breaking the compensation cycle?
Testing the memory bank. That was
That's a while ago now.
5 years ago nearly now. I think it was along the lines that the workers get stuck in that compensation cycle, and there's really only two ways that you can break that cycle, and that's either through an adverse decision or through return to work, and they're the only two really measures that you have.
And what the response and what the response was saying, Mary, was not, we don't go down these adverse paths because we're horrible. That their job is to help people who get stuck in the system and try and break that cycle. And I think the Ombudsman may have had good intentions, but she missed this, that, as you said, 6 months in, people are stuck. And if we're not applying some levers and trying to, progress them, then we end up with people stuck in the system. And in her own data, I thought it was quite laughable. She talked about two claims that, the med panel had decided that they couldn't work, even though an IME had said they could. But unfortunately, by the time they tracked them down, they both had jobs. I'm like, so hold on. So the IME was correct, they could work. And had she gotten to them before they gotten jobs, these people would have been tracked back into the system instead of progressing. And that's the bit where I think it's yes, there are some people who probably get caught up in the adverse side of things who don't, but that's why we have now 3 systems in Victoria that workers can go through to try and have that addressed. But I don't think it's the majority. I don't think the agents are evil. I think they're trying to do a job which is quite difficult.
I put out for a few things. So I get there's been that, and I understand you view statistically significant sample. It's not a representative sample. All of that, but I have had patients of mine as a treating physician that I can see no other explanation for their claims rejection than them being a KPI statistic. that it was discussed in the Ombudsman's report. Like, I've said it's work-related. The IME has said it's work-related. The investigator's gone out without the person there and come up with crap. Yep.
Yep.
So I've had my own cases. I went to the Ombudsman. I was part of the delegations because I take this so seriously. The tip of the iceberg was the Ombudsman's report, but what happens on a day-to-day basis is, in many cases, immoral and unethical. And I don't think you can hold the agents accountable for that. The insurer is WorkSafe. I think WorkSafe is doing what they can to improve. I think they're trying. I don't think they have a full picture, but they are trying to do their best in the circumstances. But I see the pendulum's gone the other way.
Too far.
And I would talk about systems as old way and new way. Old way is focus on the claims liability and what you can reduce costs on. New way is getting in early and help people. And we've just got this immense amount of data that says this way, the new way, is the best way for the worker and the employer and the system. But people are still don't kind of get that transition. And so if we can make that transition, then we are capturing the majority of people. But people do get stuck. I don't know if it's an entitlement stuck. Maybe it is. I can only hear what they say, but they're certainly stuck.
Yeah.
They get delays and delays, and they just get worn down, and the medical side of things is not terribly good, and the employer might be difficult, blah, 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 blah. So I see it as multifactorial, not just workers, not just employers, not just blah, blah, blah. It's the whole thing together.
And Mary, I think the system, to a degree, also reinforces disability on injured workers. I talk a lot about how I don't go to a doctor when I'm well. I go to a doctor when I'm sick. So if I'm a workers' comp person and I have to see a doctor every month and I've got to go to an IM every 3 months and I've got all these things going on, I must be very sick.
Yep, absolutely. And all the over-treatment, it's making no frigging difference.
Oh, yeah, the weekly physio visit for 6 months,
Well, the twice weekly physiotherapy visit in 3 years is what I'm seeing. So I shouldn't get so worked up.
So one of the things we look at, you're right there about that early care. And when Rosenberg was doing his review, I responded to that, and they were talking about, how when secondary psych kicks in and when drug dependency, and they were talking about a year. The reality is, it's, then there's data on this, at 45 days, we know it's going to be less likely someone's come back to work. It is that period where we need to be throwing at it. And if it goes past that, we need to start looking at the why, because most injuries we deal with should have resolved by then. And that's where the question about why hasn't it has to be asked. And even, we look at the liability phase. A lot of people leave the worker off work while they're looking at liability. We should be trying to get the worker back through that point. So even if the claim is accepted, they're back at work, great for both parties. If the claim's not accepted, they're back at work, great for both parties. It's not rocket science.
A couple of things. The narrower thing is Australia Post. We wrote up the case study in the Psychosocial Match Care Guide of 80 pages I talked about. We've got case studies. And they talked about it as psychosocial for mental health claims, but I think it was more than just, it was psychosocial, just a slightly different model, but they just started rehab before any liability decision was made. They just got on with it day one. And they've had fantastic results because they've got good skilled people, early resources, a collaborative approach, really deep systems to help the person. So that's the sort of the narrower side of it. The broader side of it, if I think down the eastern seaboard, I had dinner with a 35-year-old software engineer's son about 2 weeks ago. He's a software engineer at Atlassian. And what I was kind of trying to explain is, like, if they did all their coding in the first 3 months and just let it happen and didn't worry about that too much, well, it's like what's happened is there's all these errors in the coding. And so now they've got a department over here to fix these type of errors. And now they've got a department over there to make up and deal with the customer issues from that type of error. And so we've got this massive structure of dealing with all of these problems that arise from not addressing the coding in the first 3 months of getting your initial coding right. And that's the best analogy I can think of outside this area is core business is the first 3 months. If you get that right in 80% of your cases, you're going to make your life so much easier. You're going to make everyone's life so much easier, and you're going to help people, and you're going to get them back, and you're going to save money. But if you don't, then you've got all these patch-ups, because you know what it's like, Simon. 6 months, they're on 4 hours a day, they've gone down to 3 hours a day. It's lost. You know, it's like a big battle, and really good people can make a difference then and retrieve it. But you've got to be pretty bloody good to retrieve it at 6 to 12 months.
Yep. Now, Mary, we're about to wind up, but I've got a question for you which goes into one of the podcasts we're going to do at another point. We see a number of employers these days looking to save money on workers' comp by not lodging claims. How do you think that impacts the worker, the system?
Was that a quick enough answer for you?
Yeah.
I see it all the time. I see it in the common law claims. I mean, they're just like, you know, they didn't take any notice. They tried to hide the claim. You know, it took me 3 or 4 months to realise they weren't wanting to put in a claim. And it's a disaster. It's a disaster. You'll get away. Sorry, what I should say is it differently. When we talk of working with one of Australia's biggest manufacturers, their LTI rate was coming down like that, and their claims cost rates was going up like that, if that makes any sense to you. Yep.
Yeah.
So they were trying to control claims costs and, you know, miss the LTIs and blah, 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 by just sending that message to workers. So that's just a repeated thing. Did I answer your question, Simon?
Yes, you did. It's a similar, I guess, a message that we try to send out there, that it may seem to be saving you money, but it can actually make claims that do come through a lot more expensive.
Thank you. You'll get away with the small ones. The small ones will just, you know, go through Medicare or some other way. But it's the ones who can't do that, and they're the ones who will have that negative reciprocity explode in them. And they're very justified in being difficult. I would be. You did that to me, I would feel very justified in being difficult. I would feel very little motivation to help you out.
Our favourite then, Mary, is when they've an employer has not lodged a claim for 4 or 5 months, and then they want to manage the person. And then they say, well, how do we stop the person lodging a claim? So it's really hard because you've been paying for it for 5 months. You've kind of accepted it.
Yeah.
So.
Yes. Good point. Good point.
Absolutely.
Mary, thank you very much for your time today. I do appreciate I always appreciate our catch-ups. And next time down in Melbourne, we should try and catch up for lunch or dinner. Really appreciate your knowledge, your expertise, and everything you're trying to do to improve the scheme.
Thanks. Thank you. And thanks for the opportunity to talk about some of these really important things, because employers are just gold to be able to reach. It's hard for us to reach employers. And so what you're doing in kind of supporting that, employers getting that new way, the effective way, is just fantastic, Simon, and your whole team there at Aegis.
Thanks, Mary.
Thanks, Mary.
Nice to meet you, Mary.
Bye.